Thanks everyone for the picture. I'm Bob Steiner. I'm at the Department of Pediatrics, University of Wisconsin, and editor of Genetics and Medicine. And I'm also, I think I have my disclosures on the next slide. It won't move. Now it will. So I consult for a number of pharmaceutical companies. I hold equity in 4 pharma companies, some of them worth nothing right now. I intend to reference off-label use of drugs in my presentation. You can see those listed there. Here's my research support. I have patents related to newborn screening for sterile and bile acid disorders, but they have not been licensed and there's no revenue. But I am also Chief Medical Officer of Prevention Genetics, which is a genetics diagnostic testing company, and now part of Exact Sciences, the Cologuard people. So I'm going to tell you about clinical aspects of cerebrotendinous xanthomatosis. And if I end up talking about the wrong disorder, Smith-Lemli-Opitz syndrome, that's because I just came from my other patient advocacy group meeting in Seattle. And unfortunately, the 2 meetings overlapped, but I was able to make part of both meetings. So I'm going to present a couple of cases here of real people with CTX, and some of you will recognize your children here. So this 16-year-old was developing normally until about 1.5 years, and then his mother noticed that his language was not progressing very well, and she knew this in part because she's a speech-language pathologist. By age 3, he'd been diagnosed with autism spectrum disorder. By 5, other things started showing up. His vision wasn't so good, he couldn't run properly, and he was having diarrhea. By age 11, cataracts removed, and he had at least 1 seizure. And so his mom went on the internet, and next slide. There's a picture of Eric and his mom and brothers. Next slide. By age 16, his mom had done some research, mostly on the internet, and found that there are disorders with autism, cataracts, and intellectual disability, and one of the more prominent ones is Smith-Lemli-Opitz syndrome that I just mentioned a minute ago. And so her son actually entered our research study on Smith-Lemli-Opitz syndrome because that's what we thought the diagnosis was. He was nonverbal at the time, impaired gait, had a normal head size, so he didn't fit SLOS perfectly. He also had some unusual neurologic things that weren't fitting very well. Did have the diarrhea. So we did additional testing because we were a little skeptical that maybe this was something else. And sure enough, he had elevations of plasma cholestanol. And you'll hear a lot more about cholestanol today from the following 2 speakers. His 7-dehydrocholesterol level was up as well, but that can be seen in both disorders, SLOS and CTX. But the plasma cholestanol was really suggestive of CTX, and he had genetic testing done which showed 1 pathogenic variant in the CYP27A1 gene, which is the CTX gene, and he was diagnosed properly with cerebrotendinous xanthomatosis. But without the idea of SLOS as a possible diagnosis, he might still be undiagnosed today. So treatment was begun with chenodeoxycholic acid, or CDCA, which is the standard of care therapy for CTX. Next slide. Patient number 2, her father will probably also recognize this case presentation. Normal development early on, intractable diarrhea with 5 to 6 stools per day, thin liquidy stools. She was a slow learner in kindergarten, seemed to have ADHD, was in special education, had private tutoring, really trying to get her all the help they could for school, but no diagnosis at that point. Next slide. And she was 13, sorry, she's 13 when she came to see us. But by age 10 had developed bilateral cataracts. The ophthalmologist alerted parents to the possibility of a genetic condition. And they considered mainly 2 conditions, the 2 I've mentioned earlier, SLOS and CTX. CTX was diagnosed. There was increased plasma cholestanol and 2 variants in the CYP27A1 gene. Again, CDCA treatment was started. The diarrhea stopped. She gained weight. And her parents did a great job of publicizing CTX to the public for improved recognition so that other children wouldn't have to wait so long for a diagnosis, to the point of being featured on the Mystery Diagnosis television show. Next slide. So I've mentioned some of the features of CTX here. I want to talk a little bit more about those. So some of the classic early signs are cataracts and diarrhea. Now when you take your child to the doctor for diarrhea, they're not going to think of CTX first. But for truly intractable diarrhea that's very difficult to treat, and when there are other things going on, we hope that with improved publicity of this disorder that doctors will, especially pediatric gastroenterologists, primary care pediatricians, will think of unusual things like CTX. Xanthomas also occur. I think I have some pictures of those. And these are abnormal growths on tendons, especially the Achilles tendon and the tendons in the hand, but also can occur in the lungs and the brain. Intelligence, IQ, may be below normal, but not always, and certainly not early in the course of the condition. And then ataxia, difficulty walking, difficulty with balance, spinal cord problems, increased plasma cholestanol in the blood, and also increased cholestanol in tissues. This is a genetic condition. It's sometimes classified as a metabolic disorder, or a bile acid disease, or a lipid disorder. It's really all of those things. Next slide. I'm not going to go into the biochemistry here because I think Andrea will, but just briefly, it's caused by a genetic condition that leads to deficiency of this enzyme, the sterol 27-hydroxylase enzyme that normally converts cholesterol to bile acids. And the gene that, when mutated, leads to the enzyme deficiency is called CYP27A1. Next slide. Going fast because I have 15 minutes. So although CTX is rare, it's thought to be underdiagnosed, and there's some evidence that we're missing a lot of people with CTX who are out there and symptomatic, but we just haven't diagnosed them. And part of this is because the presenting signs and symptoms, the complications of CTX, are non-specific. You can't look at cataracts, diarrhea, xanthomas, and immediately come to CTX because there's a lot of other more common conditions with these things. But when they occur together, there's the hope that doctors will recognize them. There can be marked variability in the signs and symptoms, so not every patient with CTX has the same signs and symptoms, and there's marked variability in severity. Some people are very mildly affected, and some have nearly all of the complications. And the age of onset of complications differs between patients, from infancy, almost the first few days of life where they can have liver disease, to elderly patients who are first starting to have problems with gait and so forth in the late decades of life. The course is typically progressive. It gets worse with age and is potentially debilitating or even fatal if untreated, particularly with respect to the neurologic problems. Intellectual disability, autism, behavioral and psychiatric problems occur, and loss of cognitive skills, really dementia, among others. But again, that's if untreated. There is a very effective treatment. Next slide. So one of the main points from the last slide, the clinical picture is really variable. It can vary tremendously from one person to the next. Individuals with CTX are normal at birth. You can't recognize them when they're first born or in early infancy. The first symptom is often diarrhea, and that may be intractable, and what that means is very difficult to treat unless you treat the CTX specifically with CDCA. There are developmental delays, typically by the start of school. The cataracts that are seen are typically what we call juvenile cataracts. They're often first developing between about 4 and 18 years of age. And when we see bilateral cataracts, cataracts in both eyes, you should really think genetic disease first. And one of the most important genetic conditions with bilateral cataracts is CTX. The tendon xanthoma often occur after puberty, so that's not going to be a terribly helpful sign in early childhood. So our providers should not rule out CTX just because someone doesn't have the tendon xanthoma, and even older individuals may never develop xanthoma. They don't develop in everyone. Progressive coronary artery disease and myocardial infarction can occur, but they are uncommon. And autism, dementia, and paralysis can occur, again, without proper treatment. Next slide. From a review article that I had the pleasure of writing with one of the giants of this condition, Jerry Salin, who first helped characterize this condition and develop treatment, here's what we said about the neurologic findings. We said there was a broad range of neurologic findings reported, including low intelligence, pyramidal signs, which is spasticity, increased reflexes, and a positive Babinski sign, where the big toe, when you rub the bottom of the foot, goes up. Cerebellar signs, balance problems, problems speaking, and unusual eye movements where the eyes are sort of dancing around. And then peripheral neuropathy are among the most common neurologic symptoms. But also, in addition, dementia can occur, psychiatric symptoms, anything from depression to hallucinations and so forth, autism, seizures, and Parkinsonism. Really, almost every neurologic sign or symptom you can think of has been reported in CTX, and sometimes many of them in a single patient. Intellectual disability, gait disturbances are common presenting signs. Those are sometimes the things we see first. And then when we do brain imaging, because when we're seeing neurologic conditions, we see abnormalities in the cerebellum, which is important in movement, and in the dentate of the brain. Next slide. Cause, I've already mentioned this a little bit, pathogenic variants in the CYP27A1 gene leading to deficiency of this enzyme. The enzyme is important in production of important bile acids, chenodeoxycholic acid and cholic acid. CDCA is the common treatment for CTX, but some patients, especially perhaps infant patients with liver disease, are sometimes treated with cholic acid, and there are even a few adults who have been treated with cholic acid. And treatment results in increased production and the condition, when untreated, results in increased production and deposition of cholestanol in tissues. That's probably part of what's causing the complications, and we can reduce the cholestanol with these bile acid treatments. Next slide. How do we diagnose it? It's generally diagnosed when we first have suspicion based on the clinical symptoms, the neuroimaging, then we move on to biochemical testing, and finally molecular genetic analysis. Now these days, when a child, let's say, goes to the doctor with complex variety of symptoms in different organs, we geneticists especially may do a broad test. We may do something called whole exome sequencing or genome sequencing before we do any biochemical testing. And so we may come across the diagnosis based on the genetic findings. And there's a nice report from Dr. Verips, whose group suggested that the presence of 2 of 4 clinical hallmarks should prompt thorough screening for CTX. And those hallmarks can include premature cataracts, diarrhea, progressive neurologic problems, and the tendon xanthoma. Next slide. We're getting to the end here. Next slide. This, again, taken from our review article published a few years ago, shows the symptoms on the left and then what ages they show up on next to that. And the darker the color, that shows how common they are at certain ages. So chronic diarrhea occurs early and is very common. Cognitive impairment occurs a little bit later, but again is also very common. Behavioral personality disorders, psychiatric symptoms, not as common, usually a little bit later in onset. Cataracts are often juvenile, showing up in childhood, but very common by the 20s and 30s. Seizures are not terribly common, but much more common than in the unaffected general population. Mood and affective disorders we talked about with the psychiatric issues. Tendon xanthomas can occur at any age, but generally it's sort of late childhood, adolescence, very common. Foot deformities show up much later. Ataxia and gait disturbance in adulthood typically, but can be seen in children. Dysarthria, which is difficulty speaking clearly, is a late onset symptom. Spasticity and paresis and dementia, also late. But look at how dark the column is in 40s to 50s, really pretty common. Next slide. And here's a picture of a severely affected individual and showing my research mentor, Dr. William Connor, and his wife Sonia, a dietitian who worked with him. Next slide. So these are the xanthomas on the hands. Next slide. And a surgical photograph. Next slide. Oh, thankfully we've already had lunch. And this is the tendon xanthomas in the Achilles. really overgrowth of the Achilles tendons on the back of the foot. Next slide. And on the knees, these xanthomas can occur on the knees as well. Next slide. I think in the interest of time, we'll keep going. This just belabors the previous table that I showed you. Yeah, you can just go through those quickly, just showing the ages. So Dr. Birgener and Salin reported 17 patients treated with chenodeoxycholic acid. Look at this, dementia cleared in 10 of the patients. Only 2 did not improve. I mean, in what other disorders can we improve dementia? Not many. There's less disorientation and memory loss. Some of these patients were now able to speak and think rationally for the first time. Neurologic dysfunction improved, EEG and MRIs improved. Next slide. So that's in memory of Dr. Connor, my research mentor, and Andrea had the pleasure of working with him as well at OHSU. Next slide. And that is the view from my home in Marshfield, Wisconsin. Thank you.
Do we want to do, anybody have any questions before we go to the next speaker? Go ahead.
I noticed that the first patient you mentioned only had one pathogenic variant. I am also diagnosed with CTX and only have one pathogenic variant. Do we have strong evidence that it's actually recessive?
Yeah, so Sue may have more to say about this. Yes, I think there's very strong evidence that it is probably always recessive. It probably always, or 99.9% of the time, takes 2 variants. That testing was done a long time ago, so it's probably a technical issue of not. Did they find? They did find the second one.
Found it. His blood had to be shipped to Johns Hopkins, but they did.
They eventually found it. So some of the variants are going to be between genes and introns and really hard to find. Now there are some other explanations. Sometimes heterozygotes only have one variant. That allele can be overexpressed and the other allele not expressed as much. So theoretically, it's possible that there are a few patients out there who truly only have one allele, but we haven't proven that. It's a great question. Yeah, so I'm not going to be the expert there. Don't see any neurologists really. There's Florian. So it's cerebellum and the dentate, but I can't be any more specific than that. Anything to add to that, Florian?
Yeah, and like in supratentorial white matter abnormalities. So there can also be white matter abnormalities in the top part of the brain, which we call by a fancy name supratentorial. And on MR spectroscopy, there can also be some lipid peaks that you can see in the cerebellum.
Fair to say pretty non-specific. Someone who's not familiar is not going to be able to look at an MRI and say that's CTX. Is that fair?
Yeah, I think it's sort of the constellation you are alluding to, and our radiologists have actually gotten quite good at this after seeing a few, that they call the referring physician back and they say, any history of cataracts or diarrhea, and then I think it's the combination of things, so absolutely right.
I know Dr. Steiner mentioned this in his talk, but I did want to say he published this excellent review with Dr. Salin, who passed away in 2020, but was one of the pioneers of CTX research. And you hear so many of his early work, so much of it talked about in many of the talks today. Next slide, please. And so as Jean said, I oversee a biochemical diagnostic lab at Oregon Health and Science University in Portland, Oregon. And a number of you may have been there, but we have a bunch of hospitals kind of perched on the hill overlooking Portland, and we even have our own gondola that goes up to the hospital. So next slide, please. I have consulted for Leadient Biosciences and Travere Therapeutics and received grant funding from Travere. And also the OHSU Foundation, my lab, have received gifts from Travere, which have not been made specifically in connection with the research discussed today and have been reviewed by the OHSU Integrity Office. Thank you. So today I'll be talking about the biochemistry of CTX, and Dr. Skyner gave a nice introduction, and this is also a bit of a simplified pathway. And so we pretty much have one of the world experts in the bile acid pathway here. Really fortunate to have Dr. Setchell talking, and he'll probably talk more about this pathway. But shown here is the main neutral pathway in adults to the primary bile acids, cholic acid and chenodeoxycholic acid, which is initiated by a 7-alpha hydroxylation of cholesterol to, in a few steps, form this molecule called 7-alpha C4 or 7-alpha hydroxy 4-cholestin-3-one, and some of these other intermediates in the bile acid pathway that I'll talk about in my talk. And so normally chenodeoxycholic acid plays a role with shutting down this 7-alpha hydroxylation of cholesterol step. But in CTX, because of the blockage in the pathway, which prevents the production of chenodeoxycholic acid, there's a small amount of cholic acid produced in an alternate pathway through these bile alcohols that Dr. Vaz was speaking about this morning. But there is pretty much very little chenodeoxycholic acid formed. And so it doesn't provide the normal feedback to shut down this pathway. So this pathway in CTX is highly induced, and taken together with the blockage in the formation of chenodeoxycholic acid and cholic acid, very high levels of these intermediates accumulate, as shown here. Next slide, please, Jean. And so one of the main molecules that was identified as accumulating in the central nervous system and in the tissues and in circulation in CTX is cholestanol, which is formed from the thought is that this is formed from the 7-alpha C4. Next slide, please, Jean. And so normally, this is the point in my talk where I normally stop and I reference this seminal paper by Dr. Swanson and his team that was published in 1968. And so this was really the first paper that showed, identified cholestanol as a molecule in CTX which accumulated within the central nervous system. And so we are so thrilled that he's here today and will tell us about the story behind the discovery of cholestanol as the molecule that accumulated in the nervous system in CTX. Next slide, please, Jean. And so, along with Dr. Salen, who published then in 1971, another very important paper that showed that cholestanol then was elevated in the brain, in xanthomas, and in the bile in CTX, but that chenodeoxycholic acid was practically absent in the bile. And so this is a paper taken from, a figure taken from his 1971 paper that shows in normal subjects there is about a 1-to-1 ratio between cholic acid and chenodeoxycholic acid. But in CTX patients, the percentage of their total acids, they have about 80% cholic acid, but very, very little chenodeoxycholic acid. And so in this 1971 paper, Jerry Salen proposed using cholestanol as a biomarker for the diagnosis of CTX. And it's actually been used now as the primary biochemical diagnostic marker of CTX for more than 50 years. And so normally we say levels of cholestanol that are less than around 7 to 8 micrograms per mil are in the normal range. And if they're above this concentration, that's biochemical evidence consistent with CTX. But there are some issues with cholestanol. So there's an issue with the specificity for this. That means it can be elevated in other liver diseases, for example, liver diseases, and genetic diseases, for example, cytosteremia and familial hypercholesteremia. There are also issues with cholestanol as a biomarker sensitivity-wise. So what that means is it can actually be low to normal in some CTX patients. And so I'm going to tell you a little bit more about these cases today. Another thing about cholestanol is once someone goes on to treatment, this normalizes this atypical pathway and these biomarkers decrease, and cholestanol can take about 6 to 12 months to normalize on therapy. So that's a long time to wait if you're a physician or a patient to see if you're, the therapy that you're taking is effective. Next slide, please, Jean. And so this was the observation by Koopman et al. From the Netherlands that cholestanol could be elevated in liver diseases. Next slide, Jean. And so they show here the concentrations of cholestanol. And so these spots up here are the concentrations above 20 micrograms per mil in CTX patients. And then the spots down here are the concentrations below 4.5 micrograms per mil in unaffected controls. And you can see here on the right, they have the cholesterol concentrations in various liver diseases, primary biliary cirrhosis, bile duct obstruction, and you can see the levels of cholesterol are very high in these diseases. So, you know, if you have elevated cholesterol levels, it doesn't necessarily mean you have CTX. Of course, you have to take that together with the whole clinical picture. But it is an issue with the specificity of cholesterol. Next slide, please. Next slide. And so we were interested in exploring some of these other biomarkers to see if they were maybe more specific and more sensitive for CTX. Next slide. And so I've collaborated in the past with Dr. Steiner when he was still at RHSU. And we published a paper back in 2014 where we described using some of these other biomarkers as being helpful for biochemical diagnosis of CTX. Next slide. And so we had a sample come through the lab, and so this was from a 57-year-old female who had had cataracts at age 22, the Achilles tendon xanthomas at age 13, as Dr. Steiner showed, and presented with a spastic gait. And so on the analysis of the cholesterol was 8.4 micrograms per mil. And as I told you, the cutoff level is around 7 to 8. So this was very close to our cutoff. It wasn't extremely elevated. And so we analysed the sample for some of these other biomarkers, and we can see that these are clearly differentiated and very elevated. So 7-alpha-C4 was 795, and in unaffected individuals, it's mostly less than 50. And then 7-alpha-12-alpha-C4 was around 1,500 nanograms per mil, 1,500 nanograms per mil, and in unaffected individuals, it's less than 10 nanograms per mil. So these worked very nicely for diagnostic confirmation that this was CTX. And indeed, it was confirmed with a genotype with a homozygous pathogenic variant in CYP27A1. Next slide. And so I'd like to talk about another case as well that we recently published in 2021, which is a case of sisters. Next slide, please, Jean. So these were a 57-year-old female who was diagnosed with multiple sclerosis at age 38, was affected with progressive spasticity, diarrhea, tendon deposits, lower extremity weakness, which necessitated a wheelchair. And she had a 60-year-old sister who just had bilateral swelling in the Achilles tendon, so what seemed like the beginning of xanthomas and diarrhea. And so when these sisters there was a suspicion it was CTX, and their cholesterol was analysed. So the first value is the index case, and the second value is the 60-year-old sister. So both values were 2.9 and 2.6, which is clearly within the normal range for cholesterol. So these two patients or sisters had normal cholesterol. But when we looked at some of the other biomarkers, these alternate biomarkers, 7-alpha-C4 and 7-alpha-12-alpha-C4, they were clearly elevated compared to the control levels, which again is around below 50 for 7-alpha-C4 and less than 10 for 7-alpha-12-alpha-C4. And so we also, at this point, then had a reference standard available for tetrylglucuronide, which is one of the next intermediates in that pathway. And we were able to set up an assay to measure this molecule as well. And we were able to show that these sisters both had elevated tetrylglucuronide also. And again, the control level is less than 200 nanograms per mil. And they were identified to have two previously published pathogenic variants in CYP27A1. So these are a very interesting case, and we haven't seen this before, and this is really kind of an atypical biochemical picture for CTX. And, you know, we feel like there may be many more of these cases out there where maybe CTX has been ruled out before. And so we feel like these other biomarkers will be very useful in helping to identify these patients that don't have the typical picture. And, you know, they may have partial CYP27A1 activity. Next slide, please, Jean. And so shown here then are the intermediates that we talked about today that accumulate cholestanol, 7-alpha-C4, 7-alpha-12-alpha-C4, which is dihydroxy-4-cholestin-3-one, and then bile tetrol. And as Dr. Vaz spoke about this morning, these are the bile alcohols that form when the formation of cholic acid is blocked. Next slide, please, Jean. So CTX is a progressive disease in which neurological deterioration is associated with elevated, potentially toxic intermediates that accumulate, and accumulation of cholestanol in the central nervous system over time. So as Dr. Steiner said, treatment with chenodeoxycholic acid is initiated to normalize the biochemical abnormalities, stabilize disease, and prevent cholestanol accumulation. Next slide. And so what happens to these biomarkers under treatment with chenodeoxycholic acid? Dr. Salen first published in 1982 a paper where he treated a CTX patient with 750 milligrams of chenodeoxycholic acid per day and showed that their plasma cholesterol decreased and they had improved EEG. The treatment improved the EEG abnormalities. And then, as Dr. Steiner mentioned, the seminal 1984 paper where Drs. Bergener, Salen and Schaefer treated 17 CTX patients over 1 year, and they showed that neurological deterioration could be stabilized, and in all of these patients, the plasma cholestanol went down. And so fast forward, 30, 40 years to now. So currently, the chenodeoxycholic acid dose used in children is 5 to 15 milligrams per kg per day. And the dose in adults is still 750 milligrams per day. And so in the literature, physicians have reported that they use cholestanol to monitor, number one, difficulties with treatment or treatment adherence. So if a patient has a plasma cholestanol level greater than 10, that indicates that they may be having difficulties with treatment. Stelton et al. Proposed that dose adjustments for the medication could be made based on the body weight and the blood cholestanol concentration. So cholestanol is being used as a marker to make sure that the treatment is effective and so forth. Next slide, please. Recently in 2020, there was a big study from the patients, Dr. Verip's patients in the Netherlands and Dr. Federico's patients in Italy, and they demonstrated the safety and effectiveness of chenodeoxycholic acid treatment in patients with CTX from 2 large patient cohorts. And this led to the EMA approval for chenodeoxycholic acid. So it has label approval for treatment of CTX in Europe. And so one of the things they showed, again, they showed a decrease in cholestanol, so they were able to replicate Dr. Salen's paper. And I think the Netherlands patients are here at the top and the Italian patients are here at the bottom. And they had a visit at approximately 10 months and then 38 months. And this is the decrease in cholestanol compared to the baseline value before treatment. And then in Italy, they were also able to show that 7-alpha-C4 also decreased, again at around 10 months and 38 months. So this is consistent in treated patients. Next slide, please, Jean. And so again, with Dr. Steiner, when he was at RHSU, we published together a case back in 2010, so 13 years ago now, where we first proposed using 7-alpha-C4 as an improved diagnostic testing for CTX. Next slide. We described one patient that was treated with chenodeoxycholic acid, and we measured their cholestanol after treatment and their 7-alpha-C4. And actually, this is the percentage of that biomarker after treatment was initiated. And so the top one is cholestanol. So the first time point is about a month after treatment was initiated. So you can see cholestanol has only dropped down to about 50% of its original value, whereas the 7-alpha-C4 pretty much has dropped 90% in that first month after treatment. So, this led us to think that these other biomarkers could potentially more rapidly inform the physician and the patients how their treatment was working. Next slide, please. And I do want to mention this one paper from Dr. Salen, because he was looking at bile alcohols back in 1985, and he treated 6 CTX patients with chenodeoxycholic acid, and he was measuring what we call now the tetroglucuronide. There was much talk about this biomarker this morning. This is the one used in newborn dried blood spots to screen for CTX. And he showed after 1 month with a dose of 1,000 milligrams per day, which is a little bit higher than the dose that we now give, the value of the tetroglucuronide dropped rapidly. So for example, it was 300 to start off with, and then it was 10. So again, pretty much by 95%, that marker had dropped within 1 month the treatment was initiated. So much more rapidly than cholestanol. Next slide, please. And so we've been trying to generate data over a large number of patients to really kind of characterize this, and so that we can generate concentration ranges to provide back to the physician, so it's more helpful to see what's going on with the patient who's being treated. And so this is just 2 examples. So let's take the first example. So this dark red line is cholestanol, and we looked over almost a year after treatment was initiated. And the other colours here are 7-alpha-C4, 7-alpha-12-alpha-C4, and tetroglucuronide. And so you can see these other biomarkers drop rapidly within a month, whereas cholestanol, again, takes a very long time, almost a year, to come down to normal levels. And we see the same in this. This is a separate patient. So we really think these bile acid pathway intermediates and bile alcohol biomarkers decrease much more rapidly in response to chenodeoxycholic acid therapy compared to cholestanol. Next slide, please. And our study shows that measuring these additional biomarkers can provide improved biochemical diagnostic confirmation compared to cholestanol alone, especially to identify these atypical cases of CTX where cholestanol may be close to normal. And so we find 7-alpha-12-alpha-C4 to be highly elevated and a very sensitive diagnostic marker for CTX. Additional blood biomarkers may be a useful tool for more rapid monitoring of therapy efficacy in CTX within 1 to 2 months compared to 6 to 12 months for cholestanol, especially 7-alpha-C4. And so we feel that a treatment goal in CTX can be considered to attain close to normal concentrations for plasma cholestanol and 7-alpha-C4. Next slide, Jean. And so, I'd just like to say many thanks to all the CTX patients and their families for supporting the OHSU CTX research. And of course, Dr. William Connor and Sonia, who still comes into the lab and works in the lab with us, and Dr. Bart Duell, who couldn't be here today. Dr. Connor was collecting samples from the 1970s, and when he passed away, those precious samples were inherited by me and are still kept in my freezer, and we're still using them now and trying to get as much information out of them as possible. I'd like to thank colleagues at Travere. There's a long list of people here who've helped support the research, especially for providing the tetroglucuronide reference standard and internal standard, and sponsoring biochemical testing programs for CTX patients. Of course, the folks in my lab, and I think Gladys and Sam were able to come to the meeting last year, so many of you met them when they came. And my final slide, and again, all of this work was really kind of based on the pioneering work of Dr. Salen and Dr. Swanson. So I'm going to hand it over to you, Dr. Swanson, and I'm super excited to hear the story of how you figured out that cholestanol was elevated in CTX.
The only disclosure I have is that I'm a neurologist. I'm not a geneticist. I'm not a cholesterol expert, but I did have some research training before my residency in neurology. And I knew that this condition did exist because I read textbooks when I was a student and a resident, and I learned a little bit. There was one paragraph in my neuropathology text that mentioned cerebrotendinous phantomatosis. So I had it in there somewhere.
Can everybody hear?
Yes, people Oh, I'm sorry. I'm sorry. I wasn't holding that in the right place. So anyway, I knew this disease existed, and you can put on the next slide. It was discovered and characterized by this gentleman whose name was Ludo van Bogart in 1937, who was from Belgium. And this is the paper he wrote. And you can look at it and pass it around. This is his original publication that I bought from the publisher in the 1960s. And Dr. Van Bogart was a very famous neurologist, neuropathologist, who directed the research neuropathology laboratories at the institute, the Bunge Institute, outside of Antwerp in Belgium. He wrote 700 or something papers in his lifetime. And he described this condition in a pair of cousins with the pathology that's in that paper. Belgium was invaded by the Nazis in 1940, I think, and he continued to work, although they had to move the institute to a hospital, but he came back and stayed there for all of his professional career. So now we move forward to 1966. I had done my neurology training, and I joined the University of Washington neurology group in 1964. In 1967, a resident whose name was James Shimshock came into my office. He said he was rotating through neuropathology. The residents at that time would spend 6 months in neuropathology during their 3-year neurology residency. And he had this case of a patient who had died, and you can change the slide, which perhaps you can read. So this patient had been admitted to Harborview Medical Center, which was then called King County. 58-year-old man who had developed difficulty walking with his balance, trouble with his speech, and he was noted to have large Achilles tendons. And he was diagnosed with CTX, although I don't know it was called CTX at that time. He died of a myocardial infarction. And Dr. Shimshock decided to work this case up pathologically and asked, what else might we do? This is a tendon from the patient sister, I believe. Now, next slide. This is the family history of Dr. Shimshock's patient. So this was the patient, who's the male here, and this was his sister. There were their parents, and if you can see, it looks like each of their parents were cousins. And that strongly suggested that this was a genetic disease, but it was autosomal recessive. In other words, each parent was carrying one abnormal gene. Next slide. And now this is the only pathological thing that I will show, but this is a section of the cerebellum from this patient. It's cut sort of this way. The outer part is the gray matter, where the brain cells and nerve fibers connect. And in the center of it is the white matter, where the myelin sheath of the nerve fibers causes it to look white. And there you see the abnormal area, which they called a xanthoma, I gather, in the nervous system. And that was very similar to what was seen in Dr. Van Bogart's case. And then there were also some abnormalities in the lung and in the tendons and But the brain itself, where the thinking goes on, didn't look that bad. Maybe a little atrophy, but there were no xanthomas of note in the brain itself. Next slide. We decided that maybe it would be a reasonable thing. There had never been a case reported in the United States at that time, as far as we knew, to have the brain material taken down or analyzed by somebody who knew something about lipids. Next slide. Now this is John Menkes. John Menkes was a pediatric neurologist who was one of my teachers. He died about 11 or 12 years ago. Very interesting man. He had come from Vienna to Ireland to California. He had gotten a degree in chemistry and then a master's in biochemistry. And then he had done a pediatric residency and then became a child neurologist. He was already quite famous because he had described a disease of children that were associated with an abnormal smelling urine that smelled like maple syrup. And he analyzed the urine from another case and found that there were some branched chain amino acids in the urine, and that was maple syrup urine disease or maple syrup disease. He had another disease named after him, Menkes disease, although I read that someone else actually discovered it, but he was the chief resident, so his name came first, so the disease is named after him. Now, John Menkes was one of my teachers in Baltimore, and he had come to UCLA as the chief of child neurology. He was interested in, at this time, measuring lipids, cholesterol, and other things in brains of children who had died, who had had maple syrup urine disease or phenylketonuria or other disorders of the nervous system. So I called him up and he said, yeah, sure, I'd like to look at that brain. So some tissue was taken down and sent down, and I went down there for a few days to learn a little bit as well. He took me to the UCLA football game. I went to his house, and he said, well, you want to play chess with my son? I said, well, I don't know, do we have time? And the son said, it won't take long. And he checkmated me in 6 moves, I think it was. So next slide is the critical, this isn't the original slide, but it's very similar. And this is a thin layer chromatograph. So this is a standard way of separating substances on a silica gel plate. It's on a glass plate. It had been sprayed with silver nitrate, I believe, and then put into a solvent, which then moved the materials up along the silica plate. And if you look in the center, here and here, the material is placed down here, and it moves up this way. There is a single spot, and those are from brain tissue from normal individuals who had no neurological disease. That spot correlates pretty much with that one, and that's pure cholesterol. So those patients had just cholesterol. But on the right-hand side, there are samples from a CTX brain. And you can see there are 2 spots. There's the cholesterol spot, and then there's one that's up above it, and that is cholestanol. And over here is cholestanol that was there for comparison. So that was the finding of cholestanol in the brain tissue from Dr. Shimshak's patient. And that was what is in the paper that Andrea mentioned. And the next slide. And just briefly, that's cholesterol on the left and cholestanol on the right. Cholesterol has a double bond there, which is not there in cholestanol. Looks pretty much like cholesterol. Next slide. Another person that was involved is Michel Philippart. Do you know Michel? Is he still coming to meetings? No. Michel Philippart was a fellow in Dr. Menke's lab. He was also a pediatric neurologist, but the thing here, the reason I put him there is he's Belgium. He was from Belgium, and he had actually spent time with Dr. Van Bogart early on. So Dr. Philippart contacted Dr. Van Bogart and got some tissue from the original 1937 case. And there was cholestanol in that sample as well. So now there were two individuals with that condition with the cholestanol. Next slide. Now, the next thing that happened that was of interest is, well, next slide, please, was this paper that came out in the New England Journal. So our findings were in press. They'd been written up and had not yet been published. But there was a study that was reported in the New England Journal of Medicine, which everybody in medicine reads, I think, or did, probably still do. And they reported a pair of individuals who had large tendons and had normal cholesterol, and they reported this as a new disease. There were no neurological symptoms in those cases. So I was feeling, I don't know, a little feisty, I guess, and so I wrote a letter to the New England Journal, the only one I've ever written. I said, I wonder if the cases of Harlan and Silk might possibly not be a new disease, but might possibly be cases of the disease of cerebrotendinous xanthomatosis that had been described 30 years earlier. Then I had a telephone call when that letter of mine was published. I had a telephone call from New Haven, the next slide, from a person who was a neurology resident named Alan Narden. I guess that was on the previous slide. I can't read it. And Alan Narden, who was working at the VA hospital in New Haven, said, you know, I'd never heard of this, but I think I've seen a case who's in our intensive care unit, and I don't think he's going to make it. And Alan Narden then sent us some frozen tissue from that patient who died. And that case also had cholestanol present in the brain. Dr. William Stahl is in our laboratory, and he and I and Dr. Mark Sumi, we took this frozen brain and we did subcellular fractionation on it so that we separated different membranes and from mitochondria, from myelin, and found that there was cholestanol in all of those fractions, not just in the myelin, but also in the mitochondrial fraction and the nerve ending fraction. So it was in pretty much all of the membranes that were there. Next slide, please. So this is the sentence about Alan Narden. I think that Alan Narden then, he was from New York, and I think he contacted someone in New York. And I don't know if it was Gerald Salen's lab directly or if it was someone else. But at that point, Dr. Salen got into this business, and he spent his entire life, I think, working on this disease. Dr. Salen, next slide, was able to show that you could measure the cholestanol elevation in the serum. He showed that it was really, as we've already heard, a problem in producing bile acids such as cholestanol, such as chenodeoxycholic acid. He's the one who started treating people with chenodeoxycholic acid. and so on, and here we are now. So I've seen one patient that I followed for a number of years, and Dr. Salin would just, maybe it was Dr. Tint too, would send the patient the chenodeoxycholic acid at no charge, and it was a wonderful thing. And they did that for years. But I must say that the optimism that you expressed by the study by Bergener, I wasn't so optimistic. At least the patient I was following didn't really change very much with treatment for several years. So I think it can be quite variable. You can turn the slides off. Anyway, that's my story. I thought it was, you wonder, now what if Dr. Shimshak hadn't come into my office that time? When would the cholestanol accumulation have been discovered? Because it certainly wasn't something that anybody really knew about before. So thank you.
It's a great pleasure to be part of this excellent and inspirational meeting. First time here, but I hope it won't be the last time. So I was asked to give you a talk on two topics really. So one of them being the occurrence of autism spectrum disorder in patients with CTX, and the other one being the benefits of early versus late diagnosis, or really the benefits of early versus late treatment initiation. So what I will do is give, please show me my next slide. I will show you my disclosure. So I've been highly involved in the development of a newborn screening method. So the disclosures are about that. So we have a patent on that method. It was shown this morning also by Frederick Vess. We have received in-kind support for our studies from Perkin, Elman and Trevere. And then we got a research grant from the Netherlands Organization of Health and Research Development to conduct the validation study. So going into my first topic, I will discuss a paper I was involved in, but Dr. Wishart will also discuss psychiatric disturbances later on in his talk, so he will touch upon the subject again, so I'll just leave it to this paper and then leave the rest to you, of course. Before this study, there was only one report mentioning autism spectrum disorder in a patient with CTX. So, but Aad Verrips and Bianca Stelte, who are really the initiators of this paper, noticed that in the Dutch patient cohort there were definitely more patients with ASD present. So they were really wondering what was the prevalence, what is the prevalence of ASD in the Dutch patient cohort, or in general, is there an estimate to be given about the occurrence of ASD in patients with CTX? So they set up a retrospective patient file study in genetically confirmed Dutch CTX patients, and they really looked for a reported diagnosis of ASD, so really established by the DSM criteria, so the international criteria for psychiatric disturbances, and they wanted to see if there was an association between plasma cholesterol levels or either the CYP27A1 variants and either the occurrence or the absence of ASD in CTX patients. And I really also wanted to know if you would include ASD as a part of the suspicion index. I will just show it to you. Could these patients have been diagnosed earlier? So if ASD would be part of the clinical symptomatology seen in CTX, would that have led to an earlier diagnosis of these patients? So a little bit on the CTX suspicion index, please, the next slide, please. So this was developed by the group of Dr. Federico. You can see it in the topic of the slide, but it was a paper out of in the Journal of Inherited Metabolic Disease in 2014, where they developed a suspicion index, which you could use to see if a patient should qualify for biochemical testing or genetic testing for CTX. So they used three types of indicators. So either very strong indicators of CTX, so having a sibling with CTX, or having tendinxanthomas, and they put a weight on that of a score of 100. You could also have a strong indicator like the well-known symptoms of CTX, so juvenile cataracts or bilateral cataracts, chronic diarrhea, or unexplained neonatal jaundice or cholestasis. Or having the MRI findings that were just discussed, so the dentate nuclear signal alterations, but also different neurological or psychiatric symptoms, so intellectual disability or psychiatric disturbances. So the way the score works is that you really score how many of these indicators are present in the patient, and dependent on if this is a very strong or a moderate indicator, you get a score of 100 or 50 or 25 per indicator. And if your score adds up to 100 or higher, then you should do the plasma cholesterol testing for the biochemical suspicion of CTX. And if your score is really high, so 200 or higher, then you should immediately go for the genetic testing as well. So in this, what they did in this paper, or what we did in this paper, is that we please the next slide, please, is really include ASD as part of the psychiatric symptomatology seen in these patients, so as a moderate indicator of CTX. And of course, it was based on retrospective patient file study, but they assessed if the diagnosis would have been made early in these patients. So going into the results, so the Dutch patient cohort consisted of 77 genetically confirmed CTX patients, with an almost even sex distribution, as you can see, so 37 males and 40 females. And in these 77 patients, 10 were found to have a diagnosis of ASD, so that was 13% of the total patient cohort, so actually quite a large number. So the median age of diagnosis of CTX in these patients was 11, with a large range, of course, so 5 to 43 years of age. And the main symptoms seen in these patients at the time of ASD diagnosis, so not the diagnosis of CTX, but at ASD diagnosis, was diarrhea, which of course is very familiar, intellectual disability, but only 2 patients showed cataracts at the time. But if the ASD would have been included in the suspicion index, 7 out of these 10 patients would have qualified for earlier cholesterol testing. So an important thing to notice. Next slide. So we looked at the association of plasma cholesterol levels and ASD, but we could not find an association. So as you can see here, plasma cholesterol levels are more or less the same, the median, and the ranges are also more or less comparable, a bit higher in the non-ASD patients, but there were more patients in that cohort, of course, as well. And the same goes for the association between CYP27A1 genotype and ASD. No association could be detected. So in conclusion of this paper, ASD is definitely an early and probably underestimated frequent feature in CTX, which psychiatrists and other caregivers should be made aware of, for sure. So a CTX workup would definitely be advised in ASD patients if there is ASD in combination with one or more of the well-known symptoms of CTX. So this is the most important conclusion of this paper, and to make people aware. So I will leave it to that for this topic and go on to my next topic about the treatment of CTX. So I won't go into this. Yes, this has been shown to you. So the basis of the treatment of CTX is the negative feedback inhibition on the bioacid synthesis pathway. Before I go into, I will show you several papers that say that have looked at the outcome of patients being treated at an earlier stage versus a later stage. But I would like to take you back to the first patient I was involved with. This is a girl. I just started my training as a pediatrician for metabolic diseases, and one of the first patients I tended to was this girl. Presented at only 2 weeks of age with an epilepsy, for which a diagnostic work was done, of course. And she was found to have a paracovirus present in her CSF and also in other body fluids. So she was diagnosed with a paracoencephalitis, which was likely the cause of the epilepsy. So this was at least what we thought it would be. But we did also a metabolic screen, so a metabolic workup, which definitely showed the bile alcohol accumulation in urine, and we did some additional testing, of course, and found the increased cholesterol, the low CDCH, and also the low CH, so all in accordance with a suspicion of CTX, or with a biochemical diagnosis of CTX. So we confirmed this diagnosis with genetic testing, and started her on treatment at the advised dosage for children at that time of 50 milligrams per kilogram per day, so in 3 divided dosages. So we started treating her. Please take me to the next slide. But only a few weeks after, she came back to us presenting with jaundice, increased liver size, hepatomegaly. And we did some biochemical testing, and I will show you the different panels. So there's 4 panels up here. So this one showing cholesterol, CDCA levels, ALT, so liver function or liver enzymes of the liver enzyme, and total bilirubin levels. And you can see there's different shades of gray there. So the dark gray area is the period that we treated these patients with 15 milligrams per kilogram per day of candidoxicolic acid. And when she came in, you see that she had a very increased liver enzymes, so highly increased, but also, please note the plasma cholesterol or the CDCA level. It was really, really very high. So, so almost up to 500 micromoles. I don't know how that would translate to a microgram per deciliter or the units that you use here. But it was almost 500 micromole per liter, so really, really high. And of course, she had a hyperbilirubinemia. So we stopped the treatment because we considered that the CDCA supplementation at this point had a toxic effect on our liver, so resulted in liver dysfunction. So we stopped the treatment, and this is the clear area. And you can see that the liver enzymes went up just a little bit, but really normalized quite fast again. Same goes, of course, for the CDCA, went down, yeah, we stopped the treatment. And also the bilirubin levels really normalized quite fast. So when the liver function normalized again, we restarted her on treatment, but then at the lower dosage of 5 milligram per kilogram per day in 3 divided dosages. So a 3-fold lower dosage. And as you can see, we were able to maintain quite an adequate metabolic control with this lower dosage in this patient. So as you can see, the plasma cholesterol levels went further down and remains normal up to a treatment period of 114 weeks. And no more signs of liver dysfunction. And as you can see with this supplementation, CDCA levels are around the upper limit of normal. So not really high up, but just above the upper limit of normal or at the upper limit of normal. So what we concluded from this patient, please show me the next slide if you could, is that there's definitely a risk of toxic hepatitis if you do supplement young children with CDCA at the advised dose of the 50 milligrams per kilogram per day. And that adequate metabolic control could be obtained in these young patients with a 3-fold lower dosage, so the 5 milligram per kilogram per day. So this is now part, of course, also of the treatment advice for using candidoxicolic acid in young children. But coming back to the topic of early versus late treatment, so this girl was diagnosed at a really, really young age, only a few weeks old or a month old, and we started her on treatment, and now she has been treated for over 10 years. And has not shown any signs or symptoms. So this really added to the body of evidence that symptoms of CTX can really be prevented if you start treatment at the pre-symptomatic stage of the disease. What I will go into now is show you some papers which from prior studies which gave us this clue already, really. So the first important paper is that of Professor Bergener in combination with Professor Velek Zakai, who described an Israeli family. So 4 CTX patients within one Druze family, where these patients had different age of diagnosis. So patient 1 being the younger sister of a girl that was diagnosed with CTX. So she was diagnosed to family screening, did not have any symptoms at that time. Her older sister was diagnosed at the age of 7. Did have chronic diarrhea and bilateral juvenile cataracts, but had an otherwise normal development and no neurological symptoms. Their older uncle was diagnosed with CTX at the age of 27 years, and he was quite severely affected, so bilateral cataracts, xanthomas, dementia, you can see all the symptomatology here, epilepsy, pyramidal, and cerebellar signs, brain atrophy, and white matter abnormalities. So quite severely affected, and a younger uncle of at age 16 years had protected diarrhea, bilateral cataract, seizures, pyramidal and cerebral signs, and signs of brain atrophy. So definitely also more highly more involved symptomatology already. And so they followed up on these patients after 14 years of treatment approximately. please go to the next slide. And I'll show, so this is a summary of the symptomatology seen in these patients after 14 years of treatment with CDCA. So patient 1, having started treatment at an early age of 2 years, now 16 years of age, was still completely symptom-free. Her older sister was diagnosed at age 7 and started treatment at age 7, and now 21 years of age, and even had suboptimal compliance with the treatment, also did not show any signs or symptomatology of CTX anymore. So she was treated for the cataracts, and the diarrhea that she had really resolved shortly after treatment initiation. The older uncle, who was diagnosed at 27 years of age, so now 41 years of age after 14 years of treatment, did definitely shows further disease progression. So he was unable to work, further cognitive decline, motor and sensory neuropathy were present, muscle weakness. His epilepsy resolved though, so he did not have any need for anti-epileptic drugs anymore, and no pyramidal or cerebral signs. So definitely some treatment effect for sure, but also disease progression under treatment. The uncle of 16 years old, after 13 years of treatment at age 29, so he was not working, showed aggressive behavior, weakness, still had some symptoms, but no more epilepsy, so no more need of anti-epileptic drugs, and also no more pyramidal and cerebral signs. But a clear demonstration that within one family with the same genetic background or the same CYP27A1 variants, there's a clear beneficial effect of starting treatment at an earlier stage than starting it at a later stage. So going into the second study, also a study from Israel. So this is a larger study looking at 18 CTX patients from 11 Israeli families, and only 16 could be included in statistical analysis, as the other 2 were too incompliant to really to include them in the statistical analysis. And they assessed the neurological outcome in these patients in relation to age of treatment start, and looking at different neurological parameters and really trying to determine if early treatment versus late treatment, how this would affect these different neurological outcome parameters. So they looked at their data at the beginning using scatter plots and found that there seemed to be a discriminative feature between patients that were diagnosed before the age of 25 years, so were started on treatment before the age of 25, and patients that were diagnosed and started treatment beyond the age of 25 years. So please show me the next slide. It's a busy graph, so I will just direct you to the first column. So in this column, or in this part of the table, you see all patients mentioned, so 16 patients in total. 10 of them being in the early CDCA treatment group and 6 of them being in the late treatment group. And you can see here the different neurological outcome parameters and how they were scored. So a higher score means a higher neurological involvement on that specific parameter, right? So they did a statistical testing, and as you can see, all but the psychiatric features showed a better outcome in the earlier treated patient group. So all were significantly better, doing significantly better in the early CDCA treatment group. And another important thing they noticed, please next slide, is that 5 out of the 6 patients who started treatment after 25 years of age continued to deteriorate despite CDCA treatment. So another clear clue that there is a critical threshold where you can really resolve or stabilize the disease, and at a certain point you may not be able to do so because the diagnosis and the initiation of treatment starts too late. So there was another big Dutch study I was involved in, which really had more or less the same setup as used for the study I just showed you. So what we did is looked at 56 CTX patients from 36 Dutch families, all genetically confirmed, and looked at our clinical condition assessed with 2 disability skills, so modified ranking scale and expanded disability status scale. I'll just show you what these are. A diagnosis and at the last visit. Can you just move on back? And again, the CTX suspicion index was used to assess if a diagnosis could have been made earlier. So please, next slide. I'll show you the modified ranking scale. So this is a scale used, or was developed for stroke patients really, but has been used before in CTX research and I think also in other leukodystrophies. So it's actually quite a basic score, but as you can see, going up in score, if you have 1 point extra in the score, it really corresponds to definitely much more disability in these patients. And the other ranking scale I'll show you. Am I in front of you? Sorry. Okay. So in the EDSS is the same, so it's a 10-point score or scale, where if you move up in score, it really is a drop down, so more disability present in these patients, and this is a scale most often used in MS patients, but has been used also in CTX research. Yeah, next. So in this cohort, we identified 24 patients that were diagnosed before the age of 24 years of age, and 32 diagnosed at the age of 24 years or older. The mean age of diagnosis in these patients was 25 years, but of course a very large age range. So the girl of 10 days of age I just showed you, that was the patient I just discussed, but also patients that were diagnosed at 51 years of age. And when they applied the CTX suspicion index, they noticed that also in this patient cohort, the diagnosis could have been made 8 years earlier. So definitely, again, signs of a diagnostic delay that could have been prevented if we would be more aware of this condition and started to test earlier. So again, patients treated before the age of 24 years had a significantly better outcome with respect also to the scores or the disability scores I just showed you. So they defined a good outcome as having either an improvement or stabilization in disability on these scales under treatment. And as you can see, the early treated group, so the patients that were identified before the age of 24 years, they all improved or stabilized on treatment, so none of them regressed. But as you can see in the beyond 24-year age group, only 58% of the patients were able to maintain stable disease or even show improvement, and 50% in the patients that were scored on the EDSS. So very clearly, deterioration was also seen only in the patients treated after the age of 24 years. And again, I should mention this could not be explained by a difference in mean follow-up time or CDCA treatment duration. So it really had to do with the age the diagnosis was established and the start of the treatment. So I'll come to my conclusions. So again, ASD is an early and probably underestimated frequent feature in CTX. And CTX workup should definitely be included in ASD patients with different symptoms that could point to CTX. And treatment efficacy definitely is dependent on age of treatment start, where symptoms can be reversible or partially reversible at an early age, but are irreversible and progressive at a later age. And there seems to be a threshold or an indication of a threshold around 25 years of age. And of course, important with respect to newborn screening, symptom onset can really be prevented if you start treating patients in a pre-symptomatic stage of their disease. So with that, I would like to go to my final slide. So would really like to acknowledge Aad Verrips and Bianca Stelte, who have been driving all the CTX work with respect to clinical studies in the Netherlands, and Frederick Vess, on which I've been working and collaborating closely on the development of a newborn screening method. Thank you.
Thank you very much. Does anyone have any questions for Dr. Heide Cooper?
Hi, I had two questions related to the first part of your talk.
Yep.
I was wondering, what is the prevalence of autism in the Netherlands? And I was wondering, of the 10 patients that were identified, was there a gender discrepancy at all that you know of?
So I don't know the exact prevalence. Maybe you, my 1.4%. Exactly. So it's definitely much higher than the general population prevalence of ASD. So, but 1.4% in the general population. Yeah. And this is American, but it's probably comparable.
Yeah, it's pretty close.
Yeah, And secondly, no, I don't think there was. So I don't have the exact numbers in my. But no, there was no clear difference in age. Of course, it was not completely 50-50, but there was no clear sex difference between these patients. No.
Yeah, hi there. Yeah, these are really nice data, and it's clearly fairly compelling, the need for early diagnosis, I think, so that you can initiate the therapy. The real issue is a question of why, when you initiate therapy late, do you not see good clinical response? And I suspect that part of it is due to the fact that it's very difficult to get reverse transport of cholesterol and cholestanol out of the tissues once it's been deposited. So whereas if you diagnose early and you can initiate that reduction in bile acid synthesis rate and consequently sterol synthesis rate, then you can therefore prevent the accumulation of the things. I mean, I think it's maybe a little bit analogous. If you buy a new car and you take care of it, it may last longer than if you don't take care of it, and then you try to take care of it when it's, you know, got a lot of mileage on it. I think, but it would be neat if we could find a way to get some sort of reversal, you know, of the deposition of the cholesterol and cholestanol. And I think a little bit about things like heavy metals and chelating agents and how, you know, they can be used to do that. So I don't know quite how we would do it, but these are things to think about for the, if anybody's got a brilliant idea.
Organoids or something, yeah. Interesting notion. And and I still have to speculate about what is this threshold around the age of 24, 25 years? Is it like irreversible neurological damage? Of course, these accumulation of these cholesterol has been proposed to have a direct neurotoxic effect. So, is it like a critical loss of neurons, which leads to a further progression of neurological disease? We still have to find out.
How old were the patients that Bergener studied that got reversal? Were they older or were they younger? I think they were less.
Can you repeat the question? People can't hear.
I'm sorry. No, I was just curious about the ages of the cases that were reported by Bergener and Salin to improve a lot, how old they were, and whether they were older people or younger.
I wouldn't know, but I was expecting you were just saying that you were not that impressed with the initiation of therapy in your patients. So what age were they started on treatment? Were they also older? Do you remember? Or
No, the patient that I followed, no, she was older. She was in her 40s.
Okay.
She was in her 40s, I believe. Yeah.
That would, yeah.
Oh, I was actually wondering how you came up with 25 as far as the age.
So they what they did is really they plotted the data really in scatter plots really, and first looking at the data and saw that there seemed to be like a stabilization or even improvement in the data roughly until the age of 25, and then they saw a decline of some of these data points. So that's why they decided to put a threshold and then do a data analysis or a statistical analysis between before and after, and that was confirmed in the study that we did actually. So, but why it's there? It could be 21, could be, but there seems to be a critical phase or period around around 24, 25 years of age.
I was just curious. My husband was 32 when he started.
Yeah.
He did get better for the first year.
Great. It's not completely, so not everyone who is diagnosed and started on treatment after the age of 25 will regress, but some might get better. So but in general, regression, at least what we take from these studies, the patients that are diagnosed before and started on treatment, they do show stabilization and really also improvement. So, yeah.
So we have clear evidence of reduced serum cholesterol with treatment. Do we have studies on the cholesterol in the tissues before and after treatment, or in treated and untreated patients?
So we don't have brain. So there's no in CSF. Yes.
Or in
yeah.
the skin or tendons or whichever other tissues.
So I think yes, it do also improve. So symptoms, for instance, do improve on treatment. So as far as I know, but I'm a pediatrician, so I don't see them very often. But or I don't see them actually. But In general, it will help to clear the accumulation of cholesterol in tissue.
So you mentioned that the medication in children is dosed by weight, and then it stabilizes, and we're given a consistent dose in adulthood,
Right.
although we vary greatly.
Yep.
I know for me personally, I had a little bit of improvement on the CDCA, but then continued my downward trend
Right.
until I started colic acid, because I was missing all of my colic as well.
Right.
So I'm on both, and I saw an improvement neurologically, especially once starting colic. Could it potentially be that because they're dosed by weight as children, they're still producing some colic, and then as they get to an adult and suddenly get this dose, that maybe the colic is reduced and that can be no longer active?
So in children, we do see the reduction of colic acid as well, not as severe as in CDCA, but and I think the way they got to the 50 milligrams per kilogram per day was actually derived from the standard dosage of the 3 times 250. So they just really calculated, okay, a child is approximately this and that size of an adult, so we should maybe treat with 50 milligrams per kilogram per day. I've discussed it with Aad Verrips because he reported this in his papers. So how did you come to that dosage? But they really derived it from the adult dosage and started doing it. But my main point would be that it's really can be has risks in even young patients. So we do have to start at a lower dose there. Yeah.
So I have 2 sons who are now 31 and 33. So naturally, I searched the literature to find a case of somebody older than them who had improved, and I did find one woman in a French paper at Salpêtre at 43 years old who improved on her cognitive tests. But I have a question just following on what Dr. Satchel said. From other neurological conditions, is there anything that could be applied to removing the lipid deposits? But I also know that's not the only mechanism that's interfering. It's degradation of the myelin as well, right?
Yes, and of the axon of the neurons really as well.
Yeah. Is there anything from other treatments that could be applied to improve those two?
It's of course a very great, important question. I'm not aware. I think we don't understand the exact process to which the neurodegeneration occurs in CTX as yet. So maybe Florian has Dr. Eichler might have.
So maybe just first to comment on some lipid disorders that affect the nervous system that might show some similarities. I mean, I think of in adrenoleukodystrophy, when adults develop cerebral ALD, there's much more of a predilection towards the infratentorial cerebellar areas compared to children, where you don't see that often. There are other disorders such as the GM2 gangliosidosis, who in adulthood also manifest in the cerebellum, but not in childhood. Right. So I do think there's some senescence aspect that in 20s, 30s might make that structure more vulnerable to lipids. I don't have a good answer on how to access that compartment and correct the lipids there specifically, but I think it is worth thinking about what the ataxia field is doing and some of the progress that people are seeing with compounds such as tanganil and other compounds that might be applicable to cerebellar disorders here. So just to put that out there.
Great, thank you.
Okay, I was going to say, you'd mentioned that obviously you don't have a whole lot of data on treated and untreated cholesterol deposits in the brain because brains are hard to come by.
Right.
How would we go about giving you our brains when we die?
I'll leave it.
Not you specifically, y'all.
No, in general, yeah, sure.
There are brain and tissue banks that are available, at least in the United States. I think the University of Maryland has one of those sites. And so if you Google brain and tissue banks, they have really good mechanisms for doing that. Yes.
Okay, thank you very much.
All right, thank you. So I'm Brian Wishart. I'm a pediatric physiatrist. I work at Mass General in the leukodystrophy clinic there. So kind of swinging completely the other direction. I function as an amateur neurologist, an amateur orthopedist, and sometimes an amateur biochemist, but not really. So we'll talk about some stuff, my amateur delving into psychiatry, I guess. So we're going to look at psychiatry and behavioral concerns. And I changed the title a little bit from a focus on psychiatry and behavior to those with a focus on the pediatric aspect, because I think it's important to look at sort of the adults here as well and what's going on. So let me go to the next slide. That's right. It's my disclosures. We have a very small grant from Trevere that helped with this. So I will actually skip over this. You can see my description of the background compared to all of yours. What I did want to talk about a little bit was the imaging findings, because I think it's really pertinent when we start thinking about the psychiatry and the behavioral concerns and all of that and what we find. And so there's a number of aspects. We kind of see effect from all aspects of the brain when we see CTX. And so the cerebellum gets all of the talk because it's in the name. And so we see, primarily that dentate nucleus, and that's sort of the out track of the cerebellum. That's the main part that's sending signal out of the cerebellum to the rest of the brain, connecting with the basal ganglia, connecting with elsewhere in the body. You also see general cerebellar atrophy, so just the back of the brain, the whole thing is getting smaller. And then on MR spec, we see these increased lactate, lipid, and NAA peaks that are very specific to CTX, or not super specific, but specific enough. The other aspects, the cerebrum, so up in the top part of the brain, one of the things that I found as I was going through this and trying to focus a little bit more on the psychiatric behavioral aspects is that they looked at the general metabolic rates for the cerebrum, and they found decreased perfusion, decreased metabolic rate for particularly the frontal and temporal lobes, which is going to be a bit more specific and important when we're thinking about behavioral concerns as we're going through with kids. And then the basal ganglia is another big part that we see effect on MRI, and it's particularly to the substantia nigra and the globus pallidus. And we'll talk a little bit more about what that might imply. This we've kind of looked at and gone through a good sort of picture of what we're talking about. So just to give a sense, the cerebellum, basal ganglia will sit in the center there, and as the tree house, as some folks say, and then the cerebrum, which is sort of the top of that tree coming through, and then the cerebellum would be the little backpack. Go to the next one. And so classically in the past, the cerebellum got a very minor role. And this was even the first, I think this was the first picture that popped up when I Googled it, of what does the cerebellum do as an image. And it was just described as coordinates movements, controls posture, balance, fine motor, involved in motor learning. And that was sort of, that's it. That was what it was originally kind of thought of. We think about it as movement and how it kind of coordinates things. I think that's a little bit less than what it actually does and less important from what we're talking about today. So if you look at more recent ones and more complicated ones, this is what we're looking at now. And so there's certainly motor tests. There's certainly coordination. There's important parts of that. And that's all that pink. And there's a lot of it. It does a lot of the smooth movements. It does a lot of the coordination when we think about our movement and motor aspects coming from the cerebellum. But there's a whole lot of other things that it does. And it's got parts that have to do with working memory tasks. It's got parts that have to do with emotional processing, social processing, language processing, and all of these things are coming through and being coordinated by that cerebellum and affecting how we're interacting with the world as we go through things. And so if you think about the basal ganglia, again, very classically described, and when we think about injury to the basal ganglia, we think about hemibolism and other movement disorders, dystonia and that sort. And this was a very simple description that I was able to find, and it says cerebral cortex decides what to do, and the basal ganglia helps execute that smooth movement. But there's millions of nerves, millions of nerve cell bodies within that area, and so it has to be doing more. And so there was a nice paper that was only recently came out, I think in 2020, that looked at really all the connections. And I put this up here. It's a little bit busy, but what I'd like you to focus on is kind of the bolded areas here and all of the different aspects that they found that the basal ganglia contributes to. So emotion, conflict, moral judgments within that, error detection, which is a really complex thing that we do that's involved with surprise and anticipation of what's supposed to be coming, error detection, reward, language, time processing, all of these things, you see deficits when you see injury within that basal ganglia. And so these are different aspects that we see injury within CTX. And these are areas that we have to think about as we're thinking about what kind of behavioral aspects, what kind of psychiatric concerns we're going to be thinking of. And then so just to step back, you know, there's movement coordination aspect, and then there's the cognitive and emotional aspect. And we see both of these things within our CTX patients. And so the cerebellum, timing of the motor activities, control of rapid and smooth progression from one movement to the next. The basal ganglia is very important in terms of intensities of separate movements as you're going through things, the directions of movements, sequencing of multiple successive and parallel movements. But on the other side, the cerebellum helps with executive function, linguistic processing, spatial cognition, and affect regulation. And the basal ganglia has roles in cognitive function, emotional processing, response inhibition, conflict and decision-making, error detection, surprise, reward processing, and language and time processing, which we mentioned before. And they interact. And so this is a little bit complicated. It's directly out of this one study. But essentially, it showed this direct communication between the cerebellum and the basal ganglia. And they used rabies vaccine that they injected into the cerebellar cortex and watched it go up to the striatum, which is sort of the input point of the basal ganglia, with then communication back and forth. And so having injury to both of these, you can see how there's this complex interaction between both of them that's going to relate to what we see and what are the symptoms that we're talking about. And so to step back a little bit from that aspect, why are we here? We're talking about the behavioral and psychiatric presentations. And so out of France, I think, there was a good article in 2013 that looked at about 55 patients and how often are they seeing these psychiatric and behavioral concerns, and when are they seeing them present. And what they found was a little bit of a bimodal presentation. So a lot of people presented early, and then there was a late presentation as well. But often, you know, under, I think childhood they said was under, I'm going to forget the exact age. I want to say 12, 11 or 12, was when they were looking at whether or not these kids were presenting initially. And so psychiatric and other was behavioral concerns, so learning difficulties, that kind of stuff. And it's a relatively high number, 15 when you combine them together out of 55, are presenting pretty early in life. And then it kind of continues. And honestly, if you think about early adulthood, when we're talking about early treatment under 25, you know, out of 55, we're talking 22, 26 patients. So 50% are presenting with some sort of behavioral or psychiatric concern before we're thinking about early treatment. Go to the next one. So this is, so 55 patients was their overall. They did break it down. They had about 6 patients that they looked at from their clinic. And I just wanted to put this up here to sort of look at a couple things. One was the diagnosis of psychiatric illness. And so that's here. And so we have some young diagnoses of 6 and 16, and then one is an adolescent, was just a little bit less defined. And those two younger, the 6 and 16, presented with psychiatric concerns, and that was their initial presentation. But when you look at sort of the other things, aggression, irritability, ADHD were our first couple, aggression in our third with some psychosis, and then you saw some emotional lability, apathy, affect issues, and anxiety, depression across the others. I did break it down a little bit just to look at each one of those patients in a little bit more detail. And so our first patient, you know, I think it's a good look at what we're seeing in these patients. You're seeing learning difficulties really often, more often than I think is being described. And when we talk about whether or not we're having behavioral that, I think the learning difficulties is such a complex discussion of what's leading to that we don't necessarily, it could be cognitive issues, it could be behavioral issues, it could be a lot of different things, but we're seeing it in a number of patients. But that first patient really started seeing some pretty significant psychotic type behaviors pretty early. You know, learning difficulties at age 6, behavioral interpersonal relationships in issues in elementary school with some hyperactivity and impulsivity, tendency towards violence and aggression, and then ended up being hospitalized at age 13 for aggression, I think specifically towards her mother during an argument. Was diagnosed with borderline intelligence, ADHD, hyperactivity, impulsive subtype, and oppositional defiance disorder in adolescence, and had some neuropsych testing. Patient 2 was patient 1's sister, had ODD as well, and attention and issues in elementary school, was started on ADHD medication around age 9, but we ended up having to be taken off for aggression and impulsivity issues by age 11. And then our other patients that were diagnosed later, and this is looking back, right, retrospectively at what issues they had, but learning difficulties as a child and in adolescence, started special ed, and I think this patient actually had listed as not really having psychiatric or other issues, but was in special education at 7th grade with learning difficulties, which is a little bit odd. My wife is a director of special education. There's not a lot of new referrals that come at 7th grade. Often these kids are identified earlier. And then was diagnosed with depression later on in life and had some neuropsych testing that showed a lower IQ. So, and then autism, just to kind of fill it in, and I think we saw this really well, and it was really nice to see the details and exactly how you guys went through this. But I did just want to put up, this is really prevalent, and we talked about it. It was a perfect question. I had prepared that because that was going to be my point here. 13% over 1.4% is really a significant number when you're thinking about the prevalence of what you're looking at. And then the other part of this is these were all diagnoses made by a psychiatrist with the DSM criteria. So these are not borderline. This isn't, is it autism? Is it not? I think that there's probably more patients that may fit in if we followed them for a longer period of time. But a nice study that really clarified things. So, before I get to some of the data that we had, I did want to just pull this out. So this is cerebellar cognitive affective syndrome, or Schmahmann syndrome, that's been described. And so this is, I think the first paper was in the late 90s, that discussed some of the symptoms that we see that are much more related to that cognition, that affect and behavioral issues that come from injuries to the cerebellum. These are not specific to CTX. This is, I think the initial paper looked at a lot of stroke patients and that sort. But the things that they saw were disturbances within executive functioning, impaired special cognition, so visual spatial disorganization and impaired visual spatial memory, personality changes, so a lot of flattening and blunting of the affect and disinhibited or inappropriate behavior, which we would often think of as being frontal temporal issues, but this was coming directly, and these were really focused strokes that they were looking at, so it was really targeted only at the cerebellum, and linguistic difficulties. And you can see on that right side, there's a severity score, but essentially you see a lot of these issues, and executive functioning is right on the top, reasoning, calculation, affect, visual spatial issues, all the way down to that apraxia being less common but still present. With the strokes, they did see improvement over time in a lot of these symptoms. They didn't necessarily go away. But I think that's very different than what we're talking about here, where it was a one-time hit and then you're done, versus something that might be ongoing and progressive. So we looked at a number of things in our clinic. We looked at about 13 patients that we've seen through clinic. We did review the literature. There had been a literature review up to 2015, so we kind of started from there, and this had started in 2019. So from 2016 to 2019, and compared to our cohort within our group. And initially we had looked at, we're just planning on expanding what had previously been done, so neurologic, non-neurologic issues. And after meeting with some families from the CTX community and discussing some of the concerns, we did add in some of the psychiatric symptoms as well. And so looking at the psychiatric abnormalities, and this is a comparison within what we found within our cohort versus the research publications, obviously a big difference, not at all what we were seeing within the research publications. And I think some of that is just related to what's being reported and discussed and thought about versus what we were looking at in clinic. And so our patient population, and should you just go to the next slide? Yeah, so when we looked at our 13 patients and the different types of symptoms that we were seeing, about 100%, not about 100% of our patients did show some sort of behavioral psychiatric issue, and it kind of broke down in a variety of different ways. We had looked for hallucinations and whether or not that was there in the literature support, we didn't really see it there within our population. But we did see a number of patients, so I think it was 2 out of the 13, which comes out at about 15%, which fits with the paper numbers as well. Had autistic features, a lot of behavioral changes. We saw a large population with learning difficulties, which I think fit with some of the other data that we're seeing in the literature. And so I think that these symptoms are much more present. And a lot of times I think one of the issues that I see in the literature when I'm reading it is that a lot of it's retrospective. We're catching these patients at 35, at 40, and asking them how it went when they were younger, and if their mom's not there, we don't really have a good answer. So many symptoms and treatments were prevalent in our clinic, were more prevalent in our clinic than in the literature. Psychiatric changes. Speech changes were actually a big one that we saw within our clinic that I don't think were as present in the literature as being reported. And 100% of our patients were on CDCA versus a smaller portion within the literature that we had found. So now what? What do we do? Right? We know that this is prevalent. We know that this is something that we see. This is, I think, why I have a job within the leukodystrophy clinic, because I don't really think too much about the other stuff. But how do we help? How do we treat? Yeah, sorry. So you can kind of see through things. I put up pediatric thoughts. There's not a lot of research on it. There's nothing, I'm not pulling from the literature. This is just sort of things that we see in clinic and things that we do. And so, you know, the first part that I think about, especially when we're having these kids diagnosed early or we're having autistic features and we're having learning difficulties, is going to be school-based therapies. How do we get them connected with the school? How do we get services delivered through that? Making sure that they're having that IEP evaluation, that they're getting the appropriate services, and that it's being reevaluated on a regular basis, especially if we're thinking that there could be any progression. We ideally would be on treatment at this point, so hopefully not seeing any, but making sure we're getting those services through there. With this high prevalence of autism being seen here, you know, ABA therapy is an option, and we'll talk a little bit about that. Psychology management is going to be important, and then this says psychiatric management and medications. You know, thinking about early diagnosis and treatment with CDCA being very important, but then symptom management being something that we want to think about from a medication standpoint, as well as therapy and other aspects going through. And so when we think about our school-age patients, yeah, we're missing a whole bunch of parts of the slides. Sorry. Oh, there it is. Nope, I just had animations in. Yeah, I'm like, I think we're missing. But anyhow, so, you know, the IEP, there's 2 different aspects when we think about our school-age children. The IEP, or the 504 plan. The IEP has goals. It has reevaluations. It's going to go through, and you're going to be thinking about whether or not that child's making progress. Versus our 504 plan is really just going to be services delivered. And that can be any service. I think that's one part where often folks don't realize. You can get physical therapy, you can get other aspects within a 504, but they're not thinking about how to move forward. We think about it much more in children that have had a leg fracture and they need to use the elevator to get upstairs and that kind of stuff. Versus the IEP, they're going to be thinking about where you are, where we need to go, how are we catching up, and reevaluating that at least every 3 years. Some of the things that are important, you can ask for a reevaluation earlier. You can ask for a meeting on a regular basis to have discussions about how your child's progressing, where we are, and what kind of services are being delivered. And there's a whole, depending on your district, depending on where you are, a whole slew of services that we think of. OT, PT, speech are sort of the classics, but you can get orientation and mobility. Adapted phys ed is becoming much more prevalent within the school districts, where they're doing universal adapted phys ed, where they're kind of connected with the rest of the school and being able to be part of that. And I think that those types of things are really important, because one of the things that we see and that we discuss on a regular basis in clinic is when you're pulling kids out on a regular basis, maybe we're doing great for their physical development, maybe we're doing great for their handwriting and their fine motor, but what about their social development? And we really need to be thinking about that, especially in elementary school, especially in that early stages, that we're not pulling them out of school and pulling them out of those recess and those other times where a lot of that social emotional development happens, and we're being thoughtful about it and purposeful about how they're developing in those areas. So some common barriers initiating that eval, you know, the things that I push and I make sure everybody knows is this one actually. Make sure your signature is there, that consent, that signature for permission to evaluate is mandatory, and if you don't get that in, it will hold everything up. If they're young, they're 2.5, and they're going to age 3, it's different state by state in terms of the ages. You want to start early. Usually we say about 6 months before they're going to transition into the school districts. You should be starting those evaluations and meeting with people. Meeting in person can be great. It's something that we have to bring up now. It used to be the only way, but now everybody's trying to do things via Zoom. And often it's really nice to make sure you get a face in front of them. It's often easier to be nice in difficult situations, not via Zoom, which sometimes these end up being. And so I often recommend to families to try to accept IEPs with stipulations and changes as opposed to outright rejecting them, because it just restarts the process if you do reject it. So trying to work with your team, I think usually, I hear it often that families feel like it's a contentious process, but I think for the most part, when you look at the other side, most people are really trying to do what's right, and they're just trying to work within the bounds that they have, and trying to work with them will make it go a lot smoother. So, damn, this is gonna be hard. No, you can go to the next one. Does it look okay on there? No. All right. I'm going to try to do this from memory, but I don't know ABA quite as well. So ABA therapy is applied behavioral analysis therapy. It is particular towards autism. And I put the definition up because I think it's really important. There is a lot of controversy. There's a lot of people on either side of ABA therapy. But when you look at the definition, it's a science in which tactics derived from the principles of behavior are applied to improve socially significant behavior, and experimentation is used to identify the variables responsible for the improvement of that behavior. And so I had pulled out kind of these 3 different parts of it. Applied, which we can look at. The things that they think about are what is practical, what is useful for that child, what is going to be helpful on a day-to-day basis to improve their quality of life. And those are the topics, and those are the behaviors, and those are the things that they're targeting. Often it's safety, often it's interaction with peers and being able to get through the day-to-day type stuff. And those are the types of behaviors that they're going to be trying to approach and change at times. The socially significant is the same idea. How are we going to actually improve this child's quality of life? How are we going to improve their day-to-day? Does this matter to them? We shouldn't just be changing things because they're maybe not socially acceptable. We should be changing them because it'll be socially significant for that child. It'll improve their day-to-day and how they're moving forward with things. And then identifying those variables, really being purposeful about what we're doing. What is actually making a difference for this child? Not just doing it because I think this will help, but making sure that when you do that, it's having an implication on that child. It's changing what they're doing, and it's changing it in a socially meaningful way, right? And that's kind of the important parts here. And it should be very personal. It should be directed directly at your kid. It should be a conversation with the family of what is socially important, what is significant for those patients, what is significant for that family. Are they hurting themselves? Are they flight risk? Are they going to run? Are they going to do other things like that that you can try to address to help them get through that day-to-day and have a better quality of life? And that should be the goal here. And I think if we step back and think about what the final goal is, it makes that controversy kind of go away. The controversy is a lot around the tactics, that there's behavioral, there's punishment, that they withdraw rewards and that kind of stuff. And some of those things, a lot of that can be personal and how you ask them to do it and how you go through things and identify towards that child. And so I think just making sure you're having a conversation and maybe not writing off the entire therapy is important. And then I think this was transition and adult considerations. And so what we talked about here was sort of outpatient therapies. Often we see a lot of communication issues and speech deficits in our older patients, and thinking about how we're able to communicate well, improving those communication, whether that's through speech therapy or devices and that sort of thing. Strategies for managing daily tasks, and if we're having issues with our working memory or anything like that, how do we get through a memory, remember the things that we need to do day to day. Psychology management will be important as well, and then psychiatric, thinking about medications in different areas, whether it's symptom management, specific presentations from a psychiatric concern, or if it's just disease-specific management with CDCA or cholic acid. Goodness, killing me. So speech and language pathology is usually who who I refer patients to, we've had sort of hit or miss results with them. Yeah, that'll be the next one. It's the cataracts. So the things that we see are often articulation disorders, difficulty getting through the words, voice and breath management issues. And so we have had patients see our speech therapist. I will say that it kind of is transient in terms of the benefits. We've seen improved benefits, and then it often fades away as they get out of it. And as they've gotten further along, I think there's 2 patients I think about, we really haven't seen significant benefit, and it hadn't been worth it for the family because they lived further out from Boston, and trying to get them with specialists that were worthwhile. One of the things that I do think is helpful, and I've tried to push a number of our patients there, is to maybe think about augmentative communication devices and doing it earlier than later. Getting it involved, getting it as something that they're good at and they're useful and they're able to use without issue early while it's still not a mandatory thing. So if we do get to a point where we're having issues with that. We've seen issues with secretion management, some swallowing issues and it being slow. So having our speech therapist do evals on a regular basis has been helpful to make sure we're maintaining that safety and we're not aspirating or having any concerns in those regards. And they can help with strategies in terms of swallowing and that sort. That could be as simple as a chin tuck or turning your head to a certain way to make sure that swallow is appropriate. But they've been really valuable, even if it hasn't been necessarily great as patients have progressed. We've seen improvements and we've seen a lot of utility on the clinical side from the evaluations that we've had from them. Just throw it out there. It's an older one. Yeah, we're good. And then transition. You know, there's a lot of discussions about our younger patients going to our the adult world. I was down in a different topic, and there was a lot of difficulty with it. We'll just leave it at. It's a totally different world. It's not the same as pediatrics. There's not as much hand-holding. I think we have at MGH we're just lucky because we see both pediatric and adult patients, and so a lot of our adult patients get a pediatric physiatrist and a pediatric neurologist that are continuing to follow them. But often it's not the case, and I think there's a difference, and a lot of the transition talk about the difference between a transfer and a transition. And the transfer is great. We really do we want a hand off. We want that pediatric neurologist or whoever to talk to the adult person, tell them what's going on, give them that handoff. But that's not the transition. The transition should start much earlier. Transition for our pediatric patients should be starting at 11, 12, 13, where they start thinking about different things. They're preparing for that transition in terms of taking control over things, taking control over their medication, understanding their disease, knowing who their doctors are, knowing where they can reach out if they have questions, and all of those types of things. And so that really should be the lead up. That should be 6 years worth of work before you get to transitioning and then identifying those adult care providers. And it shouldn't be just suddenly at 18, okay, we're transitioning, sort of missed the boat at that point. Now we're just transferring our care to an adult provider. And I think that's it. And that one came out. So, thank you. Hunter's Hope started with helping us sort of fund this, and then it sort of led to a lot of wonderful things, and CTX and ULF for hosting so many wonderful talks and other things from the webinars and everything else. We've had a great team at MGH that's helped sort of build this to what it is, and it's taken a lot of different paths as we've gone through things, but I really think a lot's come from it, and I appreciate being part of this. It's a great group. Thank you.
Thank you.